Okay, CTG we can interpret by it is reactive or normal, suspicious or pathological. Reactive is all 4 parameters are okay. Suspicious if only one is non-reassurance. Pathological if 2 and above. Okay, these are the parameters, 4 parameters. First, baseline heart rate. Baseline should be 120 to 160. If other than that, it won't be normal. Beat to beat variability should be more than 5 beat per minute variation. Okay, there should be acceleration and deceleration should not be present. However, if there's deceleration, you have to indicate whether it is type 1, type 2 or type 3. Type 1 is early deceleration, type 2 late deceleration, and type 3 is variable deceleration. As mentioned earlier, the baseline fetal heart rate normal is 120 to 160. Tachycardia if above 160. This is due to a maternal factor and fetal factor. Maternal factor can be due to maternal fever, hyperthyroidism, drug, maternal arrhythmia. Fetal hypoxia, intrauterine infection, and fetal arrhythmia. Bradycardia can be caused by maternal factor and fetal factor also. Maternal factor, hypothyroidism. Maternal bradycardia, anesthesia, beta-adrenergic blocker drugs. Fetal factor, profound hypoxia. The second parameter will be the variability. It is normal if there's increased variability. However, if there's a decrease or absence in variability, there will be a smooth, flat baseline, the sign of fetal compromise. The causes of decreased variability due to hypoxia and acidosis, medications, sleep cycle, or preterm status. The third parameter is the acceleration. Acceleration is an indication of fetal well-being. Acceleration of 15 beat per minute for 15 seconds. This is an example of acceleration. The fourth parameter is the deceleration. You can divide into early, variable, or late. Early deceleration is related to head compression. Interventions are not necessary. Variable deceleration related to cord compression. Interventions may vary but focus on position changes. Late deceleration is related to uteral placental insufficiency. It is the most ominous and need immediate attention. This is an example of early deceleration. It's synchronous with contraction. It happened during late first stage and second stage of labor. This is type 1 deceleration. This is the type 3 of deceleration, which is variable deceleration. It is a variable in duration, intensity, and timing. This is an example of type 2 deceleration, late deceleration. The fetal heart tones return to the baseline after end of contraction. So this is the pathophysiology, why deceleration happens. Early deceleration, variable decelerations, and late decelerations. So the management, if CTG is reactive, continue monitoring, no need intervention. If CTG is suspicious, do intervention, and also FBS. FBS, I'm not sure what's that. Maybe fetal blood sampling. Anyway, CTG pathology should do delivery. Inform hemostat if CTG is suspicious or pathology. Okay, what intervention can you do? First, left lateral position. Hydrate the patient. look for the patient hydration status. You do the ARM, off Pitocin augmentation, empty the bladder, do VE for scalp stimulation, sound vibration stimulation. You might also need oxygen supplementation. If hyperstimulation, you should keep IV tocolysis. You should keep IV for internal CTG also, and repeat the CTG. Okay, this is an example of reactive CTG. How do you present this? Okay, the baseline fetal heart rate is 155 beat per minute. Beat-to-beat variability 5 to 15. Acceleration present, deceleration absent. So the CTG is reactive. Okay, this is an example of type 1 deceleration. This is another example of reactive CTG. Baseline 150, beat-to-beat variability 5 to 15, acceleration present, deceleration absent. So it's reactive. This is an example of the suspicious CTG. Fetal heart rate 160, beat-to-beat variability 5 to 15, acceleration not obvious, deceleration type 1, CTG suspicious. Let's see.